I'm enjoying our attendee and the amazing questions. Okay? If we think that in 3 days we had, I think, more than 85 speakers from all our assets, we have technology, AI, genomics, okay, and a lot coming, please. There is additional 8 sessions today. Amandeep, I'm honored to be with you.
And who's been organising all these sessions with their wonderful connections across the UAE and the Middle East?
M42 team, come on.
We really are at the nexus here of technology, sustainability and health. And thanks to Dr. Fatima and the team, because it is a full team, we're going to allow the table to be set behind us. We'll just move to the front of the stage. Dr. Fatima, the idea behind the programming is that we make sure that we cover many of the subject matters across a diverse topic area.
It's so important, in fact. After the acquisition and the merge between G42 and Mubadala Health, it's so important that everyone, okay, can see the application of all this technology on healthcare. And M42 Innovation Meeting Health, where we don't speak only healthcare, we speak health. We don't speak only curing, we speak prevention. And very, very important, okay, especially that we were also the partner, the main health partner for the first time of COP28, we speak sustainability.
Perfect. Thank you for that insight. A big round of applause for Dr. Fatima. Not only a star moderator, but a star behind the scenes with all of the connections. I've loved working with the whole team here. On that note, we set the scene there, how we're building the conversation and really giving you more insight into these areas that M42 are touching across the whole health industry. This particular area is an area that we do know of before, but really we need to have a better understanding about future innovations. Who better to take us through diabetes, care closer to home through remote monitoring than Dr. Paul Peter, a consultant endocrinologist at the Imperial College London Diabetes Centre. He has a wonderful presentation he'd like to share with you with this special health TED Talk. Please do give him a big round of applause. Over to you, Dr.
Check. Can you hear me? So my name is Paul, and first of all, thank you to M42 and particularly Dr. Fatima and Kripa, who's been so helpful getting the slides through and asking me to come down here. Ladies and gentlemen, TED-style talk, I didn't expect that, but anyway, I'll do my best. What I'm going to speak to you is not something that is uncommon, because you've heard neurosurgery, you've got some really high-funda things in orthopedics. Well, I'm just a simple diabetologist. We're going to talk about something that you will know someone about. Is there someone here who does not have, if you don't put your hands up, or does not know someone in a first relative who has diabetes? Absolutely not. I'm sure you will know that diabetes is prevalent. So I'm going to talk something about diabetes. And I think diabetes probably is the best long-term condition. Do you understand that? We call it a long-term condition. It's a disease that starts at childbirth. We look after patients who are pregnant. We take them through infancy. We take them to adolescence, adulthood, and then finally when they become old, we look after them as well. It is the ultimate disease. The disease that affects every single part of your body. No matter what, whether you like it or not, I have to look after the kidney. I have to know something about the heart. I must deal with the feelings, thoughts, aspirations of young kids, old people, everyone. So diabetes is the ultimate disease. Now I'm going to talk to you about, and the nature of my presentation is, why should we know about diabetes? Now, some of you will know, or some of you might think, I'm not interested in diabetes. I don't need to know about this. Believe me, if you're an orthopedic surgeon, if you're a neurosurgeon, you will have people with diabetes, and you will all need to know about diabetes. And if you don't know that, don't worry, you will all, maybe someone you know will develop diabetes. So I'm going to talk about why it's important. I'm going to talk about what is out there. What do I mean by that? Now, many of you will know so many things about diabetes. So yes, there are some things that we've known about diabetes. I'm going to touch about this. This is not a lesson in diabetes, but I'm going to touch about diabetes and what we know. I'm going to give you something that is new. Now, when I say new, it's been around for many years now, but then over the last 3 years, loads of developments have come, and I'm going to touch about that. And then I'm going to really see how we can apply it in the UAE, in MENA. I think we can make a big difference to the people with diabetes here. I'm going to finish up with a proposal which I think Dr. Fatima will take it forward, and then we'll be able to see a much better delivery of care of diabetes. Okay, ladies and gentlemen, that's the story. 73 million people with diabetes in MENA. And this is not my data. There's something called the IDF Atlas. They print out reports every single year, and if you look at that atlas, you'll be surprised. The number of people with diabetes. But that's okay. Yes, there are lots of people with diabetes. The problem is, that is going to increase to 95 million in 2030, and then go on and on and on. And it kills. Can you see from there? Shall I stand on the side? I just have to read it from here. Anyway, so a lot of people die from diabetes, and that's a very sad thing, isn't it? I mean, people die from renal failure, they die from heart attacks, they die from diabetes. And the next point is very important. A large majority of people are undiagnosed with diabetes. Trust me, they call it the silent assassin. The only disease that the doctor thinks the patient is unwell and the patient thinks he's okay. He doesn't come to clinic. He doesn't turn up to do his blood sugar monitoring. I tell him something's going to happen, and he says, God is great. Leave me alone. I know what to do. There's nothing I can do about it. Well, that's the reason why there are so many people who are undiagnosed with diabetes. And finally, ladies and gentlemen, don't forget, 1 in 7 live births is complicated with diabetes in the mother. So loads of reasons. Now, how does it compare with in the UAE to another place that you know? Well, I'm from the UK, so I just taken the UK data. The one thing that if you can't see it, the prevalence of diabetes is about 6.4 in the UK, and it's close to 20%. So in this group, 20% of you have diabetes. And I can tell you, as you grow older, that will move to 30, 40%. So beware of diabetes. It is prevalent. I'm going to start with a couple of cases. And these are very real cases. And the reason why I think we need to move away from the way that we manage diabetes is something else. My first case is a 73-year-old gentleman who comes to me from Fujairah. Oh yes, we get people from Fujairah. We get people from all over the place, all the way to Elaine to look after the diabetes. And it's a great system that I work in. Imperial College is really good. You come in the morning, you get your blood test done, you get the results in 1 hour, and the aim is to see the patient in 1 hour flat. And believe me, at 1.5 hours, they'll knock my door down and come inside. And I have to see them. So this 73-year-old chap who's on insulin, his HbA1c is 8.6. I will touch upon what that means. HbA1c is 8.6. He's been asked to check his blood sugars twice a day. That's minimum. Minimum. If you're on 2 injections, you've got to check it twice a day. And he has a lot of hypoglycemic events. His blood sugars are 65, 70. It's not really nice at all. So that's my first patient. My second patient is a young girl, a young lady, 34-year-old, pregnant, 5th pregnancy, 4 children between 2 years and 10 years. It's not uncommon at all. She's come in, and she has a HbA1c of 7.4%. Okay? I'll tell you what you need to know in the next slide. That's the HbA1c. And for a pregnant woman, in those 10 months that you have, we ask them to come to the hospital at least 10 times. Right? So we're talking about 10 times. She lives in Elaine, but she has her care looked after in Danat, which is a fantastic center for excellence for women and child health. And she goes there, but she comes to our center for the diabetes. Just not practical. Anyway, so there's a burden of monitoring, and I'm going to just pause there. I don't know if you know anyone who is a bad diabetic. Do you all know people who are bad diabetics? I want you to stop calling them that. Imagine. Can you all stand up for me, please? How many of you exercise 45 minutes a week, a day? Sit down. Wallah. Okay. How many of you eat only 5 fruit and veg and nothing else every day? Sit down. How many of you now never cross the 140 kilometers per hour on that really big Dubai Elaine road? Never overtake, always do the right thing in the roundabout, and always never honk when you're doing it. My God, there are 2 people like that. Sit down now, please. Now, what I'm trying to say is that we are people who break the law every day. Breaking the limit is the law. We break it. But we expect our patients to take their medicines, to check their blood sugars 4 times a day, turn up in clinics, go to school, do everything else. Never blame them. There is not a single bad diabetic. We are bad doctors. We have a bad system. We need to do something for them if you want to make a difference. So the burden of monitoring is that. And then, yes, I can check their blood sugars, but I need to have the time to really look at them. Who's got the time? I start at 7, finish at 5:30. I don't have lunch. I've got a smoothie that my dear wife makes for me, which I'll enjoy, and that's it. If I have to go to the toilet, they stop me. And my mutarjama tells me, get back in. The patient's waiting. Okay? That's how we are. Do I have the time to monitor? Well, I don't think so, but we need to find a way. Okay, next step. HbA1c. I mentioned that. HbA1c is the gold standard for monitoring. HbA1c is what determines whether you develop complications or not. HbA1c is called Maksoon or Tarakumi, the average. Okay? And if you can get your HbA1c to less than 7%, you stop people from having eye disease, kidney disease, feet disease. You save lives if you do that in the first 10 years. So get the logistics right. You've got to get the HbA1c down in the first 10 years if you want to stop heart attacks, strokes, and therein. If you want to stop them from having kidney disease and eye disease, you need to keep it less than 7% forever. How difficult is that? Okay? So yes. So what do I give my patients now? A blood glucose monitor. Have you seen a blood glucose monitor? And there's plenty of them out there. You give it to them and you ask them to check. And that's what they do. They check it before breakfast, they check it before lunch, before tea, and when they go home to bed. Now, yes, it's probably good, but do you think it's accurate? No, I don't think it is. If you did see someone like that, if he did do blood sugars 4 times a day, you'll get the blood sugar like that, and you may feel comfortable. But in actual fact, that's what is happening. And this is just a very toned down version. What you have seen, what I see in continuous glucose monitoring is that every sugar is like that. Okay? So what you're seeing is just a very small snapshot of what's happening. Totally the useless way of doing it, and that's what we've been doing for years and years and years, and HbA1c has been around for the last 50, 60 years, and that's all we have. Time to move. So do you agree with me, ladies and gentlemen, that if we have something which is continuous glucose monitoring, it will make a difference, the patients, the clinician, and the way that we will manage their diabetes? Do you agree with me? Can we do that? Oh yes, we can do it, and that's where my next few slides are going. Trust me. If I did have a system that actually checked your sugar throughout the 24 hours, real time, remember, HbA1c is not real time, it's what was happened in the last 3 months. What the heck am I going to do with that? However, if you and I, as a patient or as a clinician, had blood sugars on a real-time basis, and if that produced a result like this, the lower 2 slides are basically a trend that's happening over the last 14 days, okay? So you can see that. That's the trend. That's nighttime, daytime when he starts eating, and you can change it with during Ramadan. It just goes up, 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 and up. And of course, for a fitur and suhoor, then of course that's what happens over the 24-hour period. On a daytime, you can get reports like this. You know exactly when it's going up. You can make differences to their diabetes, their insulin, tablets, whatever you want to do, you can make a difference if you had that kind of report. What about that? And that's the new thing I was going to talk to you about. You've heard about HbA1c, but that one is what we call as the time in range. Are you still with me, ladies and gentlemen? Okay? HbA1c is over the last 3 months, how much of the sugars the red blood cell has been exposed to. Whereas time in range is not the average. And those of you who know mathematics, and I'm sure all of you do, if you have a sugar of 120 and a sugar of 60, your average will be what? 90. Yeah? That's nothing. You're having a very high sugar and you're having a low sugar, and that does not mean much. Whereas if you have time in range, which is, can you just go to the previous slide, please? It's the time that you're actually counting when the patient is with this. Anyway, it doesn't matter. No, that's okay. So the time in range is this bit, the green bit, when the patient actually in the last 14 days has stayed within normal. And that is what determines how well the patient feels. How often is the patient going up and how often is it going down? So again, ladies and gentlemen, you'll see that this has been around. The guidelines using time in range have been out there since 2020. This is 2024, and we are still having to talk about it. Time in range will tell you And if your target range is 70%, 70% of the time, the green bit, then your HbA1c will be less than 7%. You're allowed, and those are the targets. You have to keep it for 70%. The rest of it, you will have a high. I mean, if you have diabetes, if you're on insulin, you will never get it right. You will never get it right. It's very difficult. We accept that. 70% of the time, if you're on time and range, you will make a big difference. And the targets for pregnancy are even more difficult. Type 1 diabetes, you've got to get that 70%. And if you're gestational diabetes, which is people not on treatment usually, but then if they are on that, well, you've got to get 90% of the time to avoid problems to child health. Now, there are loads of people who do diabetes, and I'm embracing everyone because I want all of you, if you're in the medical profession or nursing, to take up diabetes because, as I've told you, it's the ultimate disease. But if you want to do it properly, you've got to know the facts. If you don't tell the patient that this is going to harm, they won't know. And by God, pregnancy is not a disease. It is God-given. It will happen itself. But the 1 or 2 times it goes bad, that's when all hell breaks loose. And trust me, you've got to get it right if you've got to get it right every single time. Okay? So that's what you have. You have time and range. Forget HbA1c. Go down time and range. What's out there to do this? So I've got the system. I know the basics. But do you have a way in which you can do it? Well, this has been around for some time, but just look at what we have. We have insulin delivery systems. Pumps, I mean. And there are so many of them. I used to work with Rudy Billis when he went on to do the biggest pump. You have to carry it like a knapsack. But then now you have fantastic small pumps that you can put. You can also have it on your body. Wireless pumps, loads of things. And the big thing now is there is a pump that will talk to the blood sugar. And using AI, you can actually adjust the blood sugars and stop when you have a hypo and increase insulin when the sugars are going up. Amazing. So those are pumps. But this is really the thing that I wanted you to know about. Pump is not for everyone. The pump is for a very, very few people who can manage an insulin pump. For this one is what allows us to get the advanced glucose profiles. So this you will know. Is there people here who are aware of the thing called Freestyle Libre? Okay, so if you don't, well, I'm sure there's someone here. A Freestyle Libre is available. We use it a lot in our systems. It's a little thing that will just put on your body, and it goes to your iPhone. It checks your blood sugars throughout the 24 hours. And the patient, if taught properly, and that's the thing, don't give someone something if they're not going to understand, learn, and education. It takes time. It needs to be done properly. But if you do that, you can see it in your iPhone, and you can actually adjust your things depending on that. These two are also available, Dexcom and Medtronic, and I'm not selling them to you guys. It doesn't really matter to me. These are the things that's out there available in the UAE, and it's things that we are using all the time. These two ones are a little more sophisticated ones. They're a little more accurate, but they also are used because they talk to an insulin pump. So if you have these two, depending on which insulin pump you use, these talk to each other. So it's like giving you something that actually works like an actual pancreas. Okay? A pancreas, when you've eaten at lunch, your sugar goes up, it gives you some insulin. When you have a hypo, it cuts down the insulin, and that's what these can do. This is just checking, by the way, but then you can connect it to a pump. You've got this, which I've done about 2 or 3 in the UK, because all you have to do is put an implant and then try and do it, but I don't think it's worked, so let's stick to the first 2 ones. Okay, coming back to my patient, the pregnant lady and the old man, what can we do? Can we not do something different? Can we not set up a place? So on the left side, the little elderly gentleman and the pregnant lady can stay in Fujairah or in Danat with a team, with a clinician, downloading the data that is already there up onto the cloud, and me sitting down here in a lane can actually have a look at it. You can do wonders with the things. And don't forget the fact that it has to be encrypted. The data will be encrypted. It's on the cloud. You don't have to worry about patient confidentiality. That's the project that we're talking about. We have to do that. In a place like the UAE, where you have so many distances, let's not forget that this is not going to be an option for us. We have to do it. The last slide for me, ladies and gentlemen. So this is my proposal. We've got a big setup in M42. We've got excellence in diabetes. We've got centers of excellence in pregnancy. We've got loads of things going on there. So let's collaborate. Let's collaborate from across the plaza. I don't mean just M42, but for other people as well. We need to really get a team together. You have to like diabetes. You have to like people. You've got to like talking if you want to do diabetes. If you just want to come do something, cut, chop, and go, not for you. You've got to get the right team of people. And I suggested that pregnancy is not a bad thing because it's finite, it's not for life. You can do it for 10 months, and it is going to be filled with younger people who are very motivated to be able to do what I'm asking them to do. Let's pick up a project. So my proposal is that we're going to pick up pregnancy, use what we've done here. Remember the lady who has to travel between two places? Let's do it here. Let's deliver the best state-of-the-art care for patients. Let's do it closer to home. And what do I need to tell you? You save time. I've got young girls, boys in university who come to the clinic, waste of their time. How many classes do they miss? Let's save time. Our younger generation need to do that. Let's save money, and it's COP28. I'm so sorry it's not COP22, but if you think about the distances that people have to drive from Fujairah to anywhere else, let's forget it. Let's change it. If you're serious, ladies and gentlemen, let's do something like this. Let's make pregnancy care, diabetes, the best care that we can deliver in MENA. Particularly, we want to do it in UAE. Thank you so much for listening. I'm sorry if I'm too fast and took so much time. Speed up, so I just sped up, and I didn't know I was on the Al-Ain Dubai road.
The reason we ask you to speed up is that we do want to share your expertise with our wonderful audience, and they've been super interactive over the last 3 days. Don't let me down now, please. Questions for Dr. Paul? Please put your hand up. Ah, fantastic. A lovely lady in lilac there. Can we get a mic to her? Dr. Paul, I'm just going to come around your side so I don't stand too close to the speaker.
Good afternoon, Dr. Paul. It's very insightful and really interactive discussions also about diabetes. I just want to ask how you can say that it's really, because nowadays DM2 is really, I think 7% all over the world is the percentage census, if I'm not mistaken. So how you will say that it's really a full-blown diabetes for the person, and how can we reverse it, the DM2 also, just for maybe the people around here?
If I understood you right, you were asking the diagnosis of diabetes and whether you can...
Full-blown, how can you say that it's a full-blown diabetes?
Well, let me tell you something, ladies and gentlemen. First of all, diabetes, if you think it's about sugar, it isn't about sugar. I want to kill the guy who created the blood glucose monitor, right? Because it's a blood glucose monitor, we think it's about sugar. It's got nothing to do with sugar. Sugar is something that you and I can see. The analogy that I give people is that if you have sepsis, if you have rheumatoid arthritis, if you have a chest infection, your temperature goes up. Imagine giving a thermometer to someone and checking temperatures. That's what you do with the blood sugar monitor. So don't go on the blood sugar monitor. Blood sugars are high in people with diabetes, but it affects the heart, the lipids, the blood pressure, a number of things. I didn't answer your question. The question is very simple. It's a continuum. Okay? You start, the moment your sugars are wrong, something is wrong with you. That's all we know. You lose 10 years of your diabetes the day you get diagnosed with diabetes. And my job is for you to get those 10 years back. And what we are trying to do here is get those 10 years back, and we'll do it the best way that we can. Yes, you can reverse it, but you're going to lose 20% of your weight. Okay? So if you want to lose 20% of your weight, the day you get diagnosed with diabetes, 20% of your weight, you've got a fighting chance of getting rid of diabetes. But we always tell that once you have diabetes, you never, or not usually, lose it. It's like cancer. You go into remission. And if you're on no drugs, and if it's normal for 5 years, there is a term called cure of diabetes, but that's very, very rare. Yes, 20% weight loss. Yeah, we can do that. Very difficult.
Fantastic. Thank you very much for that question. And we have an enthusiastic lady here at the front, the mic to her. Just as before we come to the lady, Dr. Paul, I want to thank you there, because part of the initiative behind these types of talks is to dispel the myths. And when you said sugar there, diabetes is often even referred to having sugar. People even say those words. So you're absolutely right that you need to break that linkage. And I'm going to bring in the audience member here with your wonderful question.
Thank you, Doctor, for this presentation. It was very insightful. So I would like to ask, does the patient have different response whether he has a underlying genetic mutation causing diabetes or not? Especially in type 1 diabetes?
Yes. So diabetes is a little more than just type 2, type 1. For those of you who don't know, there's other genetic diabetes where there are some simple genetic diabetes where you can get one single small tablet and it completely reverses it. So yes, it does make a difference. That's the question. Do we change the way that we manage them? No, because I think it all, well, everyone is individualized, by the way. So the way that you respond to your treatment differs from individual to individual. Pregnancy makes a difference. Loads of things make a difference. When you have complications, it starts making a difference. So I don't know if I've answered your question, but the answer is yes, simply put.
Okay, and do we have new treatment like stem cell treatment or
Oh, yes.
what is?
Oh yes, oh yes, oh yes. I mean, I know loads of my patients who have been to different parts of the world to get stem cell treatment, and yes, there is stem cell treatment, but like what I've said, it's not for everyone. You're thinking about getting pancreas of 3 or 4 people and then putting into someone and then trying to do that. That's your pancreas transplant. Stem cell is something that's development. It is being developed in Dubai and in many centers that is across the world. And I think it will just need a little more, to be made available worldwide and for the vast number of people. We're talking about, and it's only useful for type 1 diabetes at the moment. Okay, so that data predominantly is type 2 diabetes. We're talking about 73 million. How many stem cells do you need to be able to do that? Not very practical, but yes. I just want to, before you finish, I just want, oh sorry, if there's any.
Oh, we've got another question, so we must
sorry about this.
ensure that we honor our
Yes.
audience.
Thank you.
Thank you so much for the wonderful presentation. Although I just came at the end, I couldn't listen to all the items that you have said. But truly speaking, mobilizing the care of patients with diabetes from hospital to home is interesting, but yet challenging. Why? Because we have to fulfill the value-based healthcare, which is high quality of service, patient safety, multidisciplinary team approach. So managing patients with diabetes is not only the endocrinologist or family physician. There is a psychologist, there is an educator, there is ophthalmologist, there is podiatrist, and so forth. And it has to be patient-centric approach using certain guidelines with compassionate, integrated care, and then clinical outcome in a cost-effective way. So this kind of complicity of equations, how you can adapt it at home using the remote monitoring as only a single small component rather than having it as an ecosystem to fulfill the requirements of controlling diabetes perfectly within home. Now we are talking about hospitals at home, and now we have mobilized everything, not only diabetes, but all chronic disease, hemodialysis, ICU at home, and so forth. So can you just elaborate about your
Absolutely.
expertise in this?
Thank you so much for that contribution, and I'm just going to encourage Dr. Paul, we need to wrap in a minute, so please.
Well, thank you so much for the question. I'm going to take it in 2 parts, and I'll do it in 30 seconds each. First of all, don't get the message wrong. There is nothing to beat a really good clinician in front of the patient. Eye-to-eye contact. Whatever little I can see, I look at them and say, look into my eyes and tell me whether you take the tablet, and they all lie. They're untruthful, but it's okay. But when I look at them, there is a big difference, and they tell. So there is nothing to beat that, sir. I am not at all saying that this is going to be the be and end all of everything. What I'm saying is this would be an additional thing. You've got to see them. I am seeing my patients every 3 months, but I would like to see them. If I've got 10 appointments with the gestational diabetes, I would like to see them maybe 4 times when I have to see them. But the rest of them, if I'm bringing them only for the blood sugar monitoring, I still need to do the urine test, this, that, and everything else. So you can't do everything. It's not every single appointment, but in between appointments, if we make it work, we will save a lot of things that we are now wasting at the moment. And do not think it's impossible. We've done it in different parts of the world. This is the place that I'd like to do it, and we can do it here quite easily. Thank you so much.
Fantastic. Thank you so much, Dr. Paul.